Everyone. I'm Doug Wood, Medical Director of the Center for Innovation, and it's a privilege for me on behalf of all of those who work in the Center for Innovation to welcome you to another in the series of unexpected conversations. The mission of the Center for Innovation is to transform how people experience health. And one of our responsibilities is to also help Mayo to have unexpected conversations about how we're going to create that future. And I'm pleased to welcome today Dr. Mark Smith, who is the president of the California Healthcare Foundation, and a remarkable person, probably a complete package in innovation, as you'll hear a little bit later. But today we've asked him to talk about healthcare in the 21st century, especially primary care in the 21st century. And in that process, we hope that you will benefit from the opinion and the insights that Dr. Smith brings to us, and can think about how we might apply those perspectives to Mayo Clinic as we think about how we can provide better health for the people that we serve and the people that will depend on us now and in the future. When we think about this conversation, we want it to be available to all Mayo Clinic staff and to all of you who are part of our delivery team, and encourage you to think about the questions that you might ask Dr. Smith a little bit later as we go forward. We hope that we'll have some time at the end of this conversation for you to have your own questions or comments addressed, and do that before we're all done at about 1 o'clock. The series actually has brought a remarkable number of people to Mayo with diverse backgrounds, and Dr. Smith in his own way provides a very interesting background. He has been, I would say, more a proud parent than a CEO, but he is the founding CEO and president of the California Healthcare Foundation, and in its history of 17 years, it has really grown to be a powerful force in understanding how we can do healthcare differently. As a philanthropy, his organization has made more than $650 million in grants and has grown its assets to nearly $750 million. His background includes a medical degree from the University of North Carolina, and he is an internist who cares for patients in the HIV clinic at the University of California in San Francisco. But he also has a background in business studies with an MBA from the Wharton School, and is recognized as a national and international health policy expert. He has been in demand for speaking engagements with companies across the country, with leading conferences like Health 2.0, and has been an advisor to governments both in this country as well as abroad. And I think that as you hear his discussions with us today, you'll see why he actually has become a man in such great demand. He is a member of the Institute of Medicine, and in fact chaired one of the most important committees at the Institute of Medicine in the last decade, and that was the Committee on the Learning Healthcare System in America that produced a report about a year ago that I recommend to you all in terms of how we can transform the delivery system in the United States. So again, it's a privilege for me to welcome Dr. Smith today. We want to explore immediately 3 major areas, and I'm going to let him make some opening comments, and then, as I said, our goal is to encourage as many of you as possible to participate. So we'll have a couple of people with microphones roaming through the audience, and raise your hand or shout at us and flag us down so that we can get those, so that those who are watching on video will be able to hear your questions and comments as well. But as we contemplate healthcare in this century, I want Dr. Smith to share with you his insights about what 21st century healthcare should be, as opposed to what it's been or what it might even be at the moment. How does primary care fit into that conceptualization of 21st century healthcare? And then last, because everybody in terms of health reform in the United States is saying the only way we can really make health reform work is that we have to train more physicians especially, is that really the answer to how we move forward? Or is it time for us to think about mythbusters when we consider that point of view? So again, I'm pleased to welcome Dr. Smith. I'm going to let him start with a few opening comments, and then we'll have more of a conversation. Dr. Smith.
Well, thanks very much for the generous introduction. I'm reminded of the perhaps apocryphal story of a guy who was being introduced at the Texas Medical Society, and somebody went on and on about he has these degrees and he published these papers, and finally from the back of the room somebody stood up and yelled, "Hell, we don't want to breed him, we just want to hear him talk." It's a pleasure to be here. It's really cold here. I don't know if you all know this. I am from California, albeit Northern California, but it's really cold here. But I do have a couple of slides that fortuitously will try to answer some of the questions that you just heard asked, in part because the definition of an expert is an idiot from out of town with slides. So I have a slide or two that I want to take you through in maybe no more than 5 minutes just to kind of respond to the questions that I just got asked. So I want to try to summarize what I think is kind of 20 years of development among leading health policy thinkers about what our healthcare system should be. You are obviously capable of disagreeing with me. Just if you agree but don't like it, I would just ask that you not blame me for it. You know, last week you had somebody who gave grand rounds about some horrible disease, and you didn't blame him for that, so don't blame me for this. Our healthcare system has largely been reactive. For as long as there have been doctors and nurses, basically what we did was sit in our office or maybe in our hut and wait for people to come to us with something wrong and then try to do something about it. And we're now moving much more towards a system that is proactive. Our system has been focused on being curative. And we're now in a position, in large part thanks to the biomedical advances fueled in the last 50 years, to be much more preventative in our approach. Our system has largely been individually based, this kind of myth of the doctor. There are lots of things I hate to hear politicians say, but among the most despicable of them is between you and your doctor. Like your doctor has this huge brain that contains within it all of human knowledge that is dispensed to you kind of as an individual. And as you all know, perhaps more than anybody else, we were talking before about Mayo's brand, if you will. And my sense of part of Mayo's brand is that it has always been team-based. So the world is catching up with you. Most of people who think about healthcare recognize that modern medicine is a team sport. Our care has been eminence-driven. That is to say, how famous is the person who's rendering a judgment about what the diagnosis or treatment should be? And increasingly, we're in the era of being evidence-driven, not because you are famous, but because here's what hundreds of people over thousands of patients have discovered to be the best treatment for a given condition. We have been a very hospital-centric place. There is no more hospital-centric place than Rochester, Minnesota. When I got here, I said, so is there anything else here beside the Mayo Clinic? Yes, there's, I guess, UMR and IBM, but Mayo Clinic is kind of an icon for everybody comes to you. Which in a smaller sense is the way much of healthcare has worked, in that we build our places and want patients to come to us on our turf, largely by our schedule, by the way, and for our own convenience, as opposed to being ambulatory. That means, for those of you who didn't study Latin, the way most people are most of the time. Walking around, at home, at work, at stores, at places other than our facilities. We have been focused on a biomedical model, and increasingly, particularly in the era of chronic disease, recognize that our diagnosis, our interventions, our preventions are based on both biomedical and psychosocial precepts. And so it's not enough to just say, here's the diagnosis, here's the pill. Whether someone takes that pill, whether they can afford that pill, whether they understand what that pill is for, is increasingly important. So that's part of what I think 21st century care is about. and how it distinguishes itself from 20th and frankly 19th century as well. So what is primary care? Well, everybody uses this in a slightly different way. I have to tell you, I was a member of the much maligned Clinton Healthcare Reform Task Force. And I'll never forget one day taking a meeting with the then head of the American Academy of Dermatology. And because primary care was all the rage back in the romantic era of primary care, he walked in and said, he's head of the American Academy of Dermatology, and not knowing that I was a physician, told me, we are primary care providers for the skin. Which, of course, raises the question of whether nephrologists are primary care providers for the kidney, right? So here's my completely idiosyncratic definition of all the things that primary care can or should or sometimes does mean. The first contact, the first place you pick up the phone and call or go in if you've got a problem. The people who care for common routine conditions as opposed to rare, esoteric, life-threatening conditions. The people who take longitudinal responsibility, who see you this year and next year and the year after, as opposed to being one-off proceduralists. The people who care for the whole person, that is to say, in an era in which decisions about different treatments are increasingly driven by personal preference, the person who can integrate some knowledge of you as an individual with a knowledge of the likelihood of success of, say, surgery versus catheterization versus medical treatment. The people who coordinate the various specialists who swarm over us, particularly if we have multiple diseases, and interestingly, the generalist perspective. It turns out that if you have back pain and ask a panel of back surgeons or neurologists what to do about the back pain, they will have a different view from a generalist who sees back pain. So in some sense, when we talk about primary care, we're talking about, to some extent, all of these things, and yet I can see circumstances in which any one of them might not be provided by someone that we would currently call a primary care physician. So if your main problem, your only problem is congestive heart failure, it might well be that a cardiologist is your, quote, first contact, is your generalist perspective. So a couple of weeks ago, Tom Bodenheimer and I wrote an article in Health Affairs, which I commend to you, called Primary Care Proposed Solutions to the Physician Shortage Without Training More Physicians. We do not believe that you don't need more doctors. We don't believe that we don't need more primary care doctors. But as Doug intimated, I'd like to suggest to you there are 5 ways that we will meet the shortage of primary care services. 1 is through primary care physicians. 2 is through non-physician licensed personnel, advanced practice nurses, physician's assistants, pharmacists, dentists, others who have a particular role to play with long, expensive professional training. 3rd is through non-licensed medical personnel, assistants, technicians, promotoras, health educators. At Virginia Mason, they call them flow managers. People who haven't been to school for 9 years and don't cost $150,000 a year, but can do some tasks in the healthcare system that need doing. 4th is patients themselves. When I was in training, to diagnose strep throat took someone who'd been to school for 13 years. You had to feel the nose, examine the exudate, interview the parents, take the temperature, take a swab, make a guess, and in 48 hours or so, you'd get an answer. Now, the diagnosis of strep throat can be made in 3 minutes for $5 by a high school graduate. And so, in fact, while we argue about how to pay a pediatrician enough to make a living diagnosing strep throat, and we argue about how many nurse practitioners can be allowed to diagnose strep throat, my own view is the average well-motivated mother can diagnose strep throat. And all around us, in everything we do, whether it's banking or research or travel, we now do things for ourselves that 20 years ago required a highly trained, highly paid professional to do for us. My view is part of the answer to how we meet this shortage is unleashing the capacity of enabling technology that we have all around us to allow patients to do much more for themselves that we are currently doing, in the same way that we do much that librarians and travel agents and bankers used to do for us. And lastly, technology. There's no other industry that would face a crisis of affordability and reliability and say, hey, let's solve that by throwing more people at the problem. So there are lots of things that we now do that don't require humans, and my view is if we can overcome the political and economic barriers, there are lots of ways in which we can meet the needs of patients far more affordably, far more conveniently for them by applying technology as opposed to throwing people at the problem. I just want to show you one thing that illustrates how a redesign and reorganization of our thinking about who does what has an impact on our notion of how many primary care doctors we need. This is Virginia Mason's value stream mapping for migraine headache. On the top is their current or their former practice, which starts with a patient making a phone call for an appointment to a primary care doctor. The red means that that is low value. They then see a primary care physician of variable value. They then go to an ER, which is low value, have an MRI, which is insane, see a neurologist, which is avoidable and low value, another primary care visit, another primary care visit. If you calculate how many primary care doctors we need based on this practice pattern, well, here are 3 primary care visits, none of which is of high value. Their redesign of this value stream starts with a call which is given by triage, evidence-based contact, and if necessary, an advanced practice nurse doing evidence-based contact, and then telephone contact. So in many ways, the answer here is not training more primary care doctors, it's having primary care doctors do what we need primary care doctors to do. I'm going to end my slides with this because it talks about how primitive our industry is with regard to use of data and use of technology and use of insights into human behavior to be as preventative and as restorative as we could be. Anybody know who this is? Gary Love? PhD economist, former faculty member at Harvard. He's now the CEO of Caesar's Palace. I once heard Gary Loveman say there are only 3 things that get you fired at Caesar's Palace: stealing money, sexual harassment, and running an experiment without a control group. If you go to Caesar's Palace and you put your loyalty card in the slot machine at Caesar's Palace, the reason they have that card is not to promote loyalty, it's to gather data about you. And they put that data together with hundreds of thousands of bits of data about you and others so that they know if you go to Caesar's Palace and spend the weekend there and lose $500, you turn to your spouse and you say, honey, I had a great time. Let's come back to Caesar's Palace. If you lose $500 in 2 hours, you turn to your spouse and you say, honey, I had a crappy time. Let's never come back to this godforsaken place again. So what happens is when you put your loyalty card in the slot machine and the slot machine knows that you're down $300, someone will sidle up to you and say, how you doing, Dr. Smith? And you say, I'm having a terrible night. They say, how about tickets to Celine Dion? How about a meal at Picasso? How about we comp you a room? Maybe you look like a dancer. We put you in the VIP line at the disco.
There's something wrong with my loyalty card then.
Right. And so at the end of the weekend, you've still lost $500, and you say, boy, I had a great time at Caesar's Palace, and come back. So the lesson of that story is that the gambling industry is better than we are at understanding their clients, predicting the future, and intervening to change it. They're relying on data they've been collecting for years. We've been collecting data for years, largely in literally medieval fashion, though you're better. I mean literally medieval, right? Vegetable pigment on smashed wood fibers. Literally medieval, right? But so now we have an increasing amount of data, not only from our own encounters with patients, but their encounters with Twitter and Nordstrom's and all sorts of other places it's available for us to have a system that actually anticipates the things that will go wrong with them and intervenes both with our own behavior and theirs to prevent it. That's the future of 21st century medicine. And primary care docs have a huge role to play in that, but it will not be by doing diagnosis of strep throat and things that we needed to do 20 years ago. It'll be by understanding and managing these teams of people that need to care for people. It'll be by building personal relationships with patients that can inform and motivate their behavior change, and being part of an enterprise that can integrate all the biomedical information that we've got to have to offer patients the right decisions. So that's my brief screed.
And that's a great start. So again, for those of you in the audience who want to have a comment or a question, hands up, we'll get a microphone to you. While you're thinking about that, I'm intrigued that perhaps one of the things about the new era is do-it-yourself medicine.
Mm-hmm.
So there's probably more to it than just do it yourself. How do we reach that combination of technology and knowledge and delivery that can actually help the mom at home go beyond just the diagnosis of strep throat, but figure out what do I do next?
Yeah. Well, it's an interesting question. I think it's a combination of really two things. It's a combination of some acculturation and learning and getting comfortable with stuff. Anybody here ever bought their own plane ticket online? Anybody uncomfortable the first time you did it? I was, but you get used to it, right? Anybody ever use an ATM machine? Well, the first time you used it, it was a little uncomfortable. There are people in this room who are old enough to remember when you needed to have a doctor's prescription to get an Advil or Benadryl or a pregnancy test. So my sense is, first, it's about people kind of getting comfortable with something that's new and maybe a little scary at first. But second, it's about having appropriate enabling technology that allows us to safely do things that we couldn't otherwise do. I'm old enough to remember there was a horrible research program called BRS Dialogue. Do you remember in the early days of the interwebs? That was kind of a very clunky thing that you needed to be a librarian to handle. So we now walk around with these amazing devices in our pocket, and we go to Google, and we go, bam, do something that 20 years ago would have required a library, a 2 or 3 hours work from someone with a master's degree to find. So I think there are opportunities in healthcare that are a combination of people getting used to something a little new and are providing enabling technologies. It is now a technically trivial matter to allow someone to read a strep diagnosis like they read a pregnancy test and have protocol-driven care based on the result of that diagnosis. So whenever we move from art to science, when we move from, I know what to do because I've done this 30 years, to I know what to do because the evidence says do it, we're closer to being able to translate that care down the skill set level to less highly trained and highly paid people, and eventually, I think, often to patients themselves.
Mr. Geisler.
Hey, thank you very much. Thank you for your insightful comments, and I do agree with what you said, so I'm a fan. One of the things you mentioned was that the future of healthcare is going to depend more on teamwork versus individuals.
Yes.
And we at Mayo have been practicing teamwork for a long time, so it's hard for us to understand why the rest of the world doesn't see the advantages of integrated practice.
Yes.
What are the barriers to the system to not being a system? In other words, what are the behaviors that say I'm much better off working individually than I would be in working in teams?
I think the two principal barriers are economic and cultural. It is still the case that in many circumstances, the activities that get paid for are activities that doctors do, and you therefore do those activities because those are the ones that get paid. It is also, however, the case that I think we don't go nearly as far as even the economics would allow, because doctors, oh God, doctors. So my first week of medical school, I was congratulated by some dean for having chosen the last profession in America where nobody could tell me what to do. Some others of you had a similar experience. It's actually true. Part of the reason why doctors are doctors is because many of them don't like organizational work. So part of why doctors, at least until relatively recently, chose this profession was precisely to avoid teamwork. So some of this changes with age, like the ability to type, right? And so I think today's doctors have a different attitude, but for doctors of a certain generation, I just think it's part of their DNA to be autonomous, to be independent, to be in charge, because that's part of the deal that they signed up for. Now, that can change, as with most human experience. If you can show people that they have a better life operating in different fashion, I think that can change. But I think the cultural thing even kind of transcends economics. The economics is hard, but the cultural thing, I think, transcends economics sometimes in terms of it being an obstacle to acting in a different way.
Yes, sir.
Hi. Thank you for a very insightful presentation. I have a question about recent news about 23andMe last week from FDA.
Yes.
And how we can learn from that incident, how to preserve innovation, but also with the proper guidance for how to helping from medical side, how to patient understanding what the results mean.
Right.
And how that comparison, the technology evolving from the 1999 Napstar to today's Pandora or Spotify, because this basically similar. I see the similar pattern, evolving. Thank you.
So that's a lot. Everybody know what 23andMe is? So 23andMe is, spit in a tube, get your genetic profile, find out how many of your ancestors are from Ireland and how many are from Swaziland, and they were recently kind of dinged by the FDA. So I think there are a couple of lessons there. One, so when I was a medical student, I was told, in 10 years, genetics are going to change everything. And then when I was a new faculty member at Johns Hopkins, I went to a grand rounds and they said, in 10 years, genetics is going to change everything. That was 20 years ago. And about 5 years ago, we had the speaker come talk to our board. He said, let me tell you something. In 10 years? So, the irony, I think, here is there is eagerness for this information among the public, among lay people, in part because we have hyped its promise. And that hype, as is so often the case, has gone beyond what the actual evidence says is available, high-quality information. But the fact that so many people have signed up for 23andMe is evidence kind of the hunger for this information. It's this wellness. These are largely young people. They're not trying to figure out how to cure something. They want to know what they got. They want to know what they're susceptible to. They want to know what their chances are. So there's the same people who are buying Fitbits are spitting in a tube to get 23andMe. And they're also going online with all sorts of other unscientific interaction with the healthcare system, like Yelp, right? So if you don't like your rating on Yelp or Best Doctors or any of these other completely unscientific black boxes, the fact is the reason that they are there is because there's great hunger in the population for the information. So I don't know enough about the accuracy of the alleles. So it may well be that it turns out that they've hung out a little over their skis in terms of what they could promise. But I think part of this problem that we have is the clash between our hyping the promise of genetic information and the hunger that people have for some insights into what they can do to change their outcomes in the future. So I don't know how that'll turn out, but it's another example of how much is happening about healthcare that's really outside the control and the purview of our system. Patients like me, anybody ever seen Patients Like Me? I mean, there's a lot of stuff going on out there that's kind of not in our domain, and it may well be that they've made some serious mistakes, or it may just be that our domain is desperately trying to contain kind of everything that touches up against our domain and define it by our rules, which are rules that other people don't play by. Do you know what I mean? Yeah. Yes, sir.
Hi, Dr. Smith. Thank you for being here, and our condolences on the weather. It's actually going to be even colder this weekend, so If you're staying, my apologies. I'd like to hear.
God love you.
I'd like to hear your thoughts on, I found very invigorating your conversation on, healthcare then and what we're evolving to right now. But I think another factor we need to consider is lifestyle, patient lifestyle, particularly around diet, particularly around sedentary lifestyle. I almost feel that primary care, it has another thing, this other thing that is working against it. What are your thoughts on how does it take that, our lifestyle and our culture into consideration to try to deliver, the great care that it wants to?
Yeah. So this is unexpected conversations, right? So I'm going to give you an unexpected and a little bit heretical answer to that. I think the problem with obesity and diabetes is much more complicated than even our most ardent public health advocates give it credit for, and I am not optimistic about the efficacy of exhortation in the clinic to get people to get off their couch and stop eating ding-dongs. So why is it that we have this problem? We have this problem, in some ways we are as often victims of our own success. Most of human existence and most of humankind today is in a desperate struggle to produce enough calories to survive. And the success of the American industrial agricultural system is such that we basically give calories away for free. So when McDonald's supersizes something, it's because the cost of the food is trivial compared to these other transportation, other costs. So that's one side. Second, most of humankind is in a desperate struggle against back-breaking, debilitating labor that burns up calories. We sit on our asses all day. So we've got several million years of human evolution that are colliding with 100 years of industrial development and agricultural efficiency, and there are much bigger issues here than willpower. There's farm policy, there's zoning, there's all sorts of things. So don't get me wrong. I'm all for the role of primary care physicians in helping people understand their individual risk. I think the integration of data can help personalize. This is not just you will have a greater chance, but given your genetics, given your family background, given your hemoglobin A1C, given your blood pressure, you have a 27% chance of having kidney failure by the time you're 60. I think that can help in motivating people, but I am not optimistic that all the exhortation in the world is going to overcome these much bigger social forces, and I suggest that all of us as health people and public health people have to kind of be involved in larger political movement about what farm policy is and what zoning policy is and what all sorts of, now there are things, there's design of buildings. We walked up 4 flights and down 4 flights today. There are things we can do behaviorally, there are things that employers and others can do about food, but I think it's a much broader issue than primary. It's another one of those things I would hate for us to hold primary care people responsible for, like gun violence and slipping in the home and depression and mental illness and global warming and all the other things we want primary care docs to do. That makes sense?
Was that the new renaissance of primary care?
Yeah, the romantic period. Right?
Dr. Green.
Yeah, so thank you. So that's one of my questions. We have a lot of health disparities in the country, whether culturally, geographically, with very complex sort of chronic disease that may have been, like you said a minute ago, dealt with earlier by prevention, all kinds of other things. So how would you propose the medical system starts to deal with those and have a new conversation about that? Because that's a big challenge for us all, extremely costly. I led a group of medical students this morning into a dialysis unit where a lot of the people had hypertension, diabetes. The cost is much less early on, and all those things you mentioned on your chart about the educational parts that we can do. We don't do them, not very well at all, but we pay for dialysis, which is a huge cost to our country and the healthcare system. So those are some things that I just want to get your comments on. Thanks very much.
Yeah. So first, I think while I had a list of what I think is the promise and capability of the system, our ability to achieve these things is still way far from achieved, and there are insane reimbursement policies. So the notion that we would not pay for your diabetes strip, but we pay for your amputation. I mean, how unthinkable is that, right? So there's lots of stuff in the way we pay for things and the way we're oriented that is just insane and falls far short of the capabilities that we now have. That's number one. Number two is, I think it's important to recognize that doctors, nurses, other health professionals have a wide range of political and social views. So I'm very committed to overcoming disparities, but I suspect there are some people in this room who might have different political views. They may not have signed up for overcoming disparities, but they did sign up for providing high quality care to everybody that walked in their office. And so my view is, in some ways, the base attitude we must adopt is that every patient gets high quality care, and that means evidence-based care, and that means standard work. And the other advantage of standard work is it does not eliminate, but it reduces the chance that your or my or somebody else's individual prejudice, knowing or unknowing, might work its way into how we treat a given patient. Whether that patient gets offered catheterization or not, whether that patient gets aggressive education about their disease or not. So I think standard work is another bulwark against disparities. Frankly, collecting the data. If there are still many places I can go and say, well, gee, what's the hemoglobin A1C of your black patients? I said, well, we don't collect that data. Well, how are you going to overcome disparities if you can't document them? So there's still lots of places in our system where information that would be relevant, because we know people get differential outcomes and differential care, is not collected, I suppose, either because it's inconvenient or maybe because it's not politically correct. So I think we do need to standardize the collection of that data. And then lastly, I think it's important to recognize, and please understand, I'm not saying this about you. There are some in kind of the disparities movement who I think veer towards stereotyping. When we say patient-centered care, we mean individual patients, not some group of patients in some category that I made up. So some Latinos wear Adidas and some Latinos wear Nikes. Some women like Doritos and some like Tostitos. There is a tendency sometimes in social movements to start with the category and then try to define some set of preferences or needs. I'm an AIDS doc. My patients are as different as any patients with any other disease. They have different preferences, they have different capabilities, they have different needs. So I think it's important, part of the way we overcome disparities is by treating people as individuals and figuring out what works for them, as opposed to assuming that Latinos or poor people or people with AIDS have some one set of needs or preferences. That's my answer.
So, go ahead.
So, Dr. Smith, I have a related question. So I think I'm putting myself in the place of my friends who are lawyers, and they were at a New York law firm 10 years ago, and someone was talking about LexisNexis and how that was going to change their research.
Yes.
So you're kind of a similar guy to me. Now it's 2013.
Yes.
But 2013, I know a lot of unemployed lawyers or way underemployed lawyers. So do you see that kind of wave hitting medicine 10 years from now?
I do, if we start building more medical schools and saying we need to train lots more doctors. That's part of why I'm arguing the problem is not that we need more doctors, it's that we need doctors to be doing different things, and we need other people to be doing doctor things. It actually is a concern of mine that if our answer to this shortage is to crank out lots more doctors, we will soon find ourselves where either there's not a lot for them to do, or they are desperately holding on, as they're beginning to do now, frankly, holding on to doing things that they shouldn't be doing because that's the only way they can make a living. So, this obviously varies by specialty, by geographic area, by prestige level, but the notion that we should ever have doctors typing in a blood pressure. It's not that doctors are too good to type in blood pressures. It's that any system that is paying a doctor's salary to do clerk's work can't be an affordable system, an efficient system. So my sense is if we strip away all the things that doctors, and for that matter nurses, are doing that somebody else could do, and if we reorganize and re-engineer our work, you can pick Lean, you can pick Six Sigma, you can pick whatever, to stop having people, as I said to some of you before, there are lots of studies that show that nurses on an inpatient unit sometimes spend the majority of their time looking for things. They're looking for gauze, they're looking for patients, they're looking for a wheelchair, they're looking for a gurney, they're looking for medicine. So the answer to that is not to train more nurses, it's to reorganize the unit and the work such as to be able to take advantage of their capacity. But so I think, that's a long answer. My sense is that doctors can, and I by the way, I think an attempt to control healthcare costs by jamming doctors' salaries may feel good to some haters, but is a completely insane way to go about securing the cooperation of the people whose enthusiastic participation you need the most to secure the success of the enterprise. And so it's nuts to say, I'm going to cut your pay. What we ought to be saying to people is you can maintain your income, you can increase your income, or you can keep doing what you're doing, but not both. Right?
Barb, did you have John?
Oh. Dr. Smith, thank you for being here as a fellow Californian who moved to the Midwest. I'm still trying to figure out why. And who went to college at Mills. I'm so glad that you're here. I am one of the staff chaplains. My name's Michelle. And I'm wondering, since you mentioned teamwork and working together much more, have you encountered or utilized or considered utilizing chaplains in customer service and service recovery? I know I've tended to go into rooms after there was a bad interaction with either a physician or some other staff member and was able to kind of give them that boost, similar to, here, have some Celine Dion tickets, but kind of turn the situation around.
Second prize is 2 Celine Dion tickets.
But have you considered that, or for, I don't know if you already do that or have seen or heard of things like that?
So the place where I have seen chaplains, where I'm familiar most with chaplains and their contribution, is in palliative care. And our foundation does lots of work in palliative care. And frankly, in California, there's a general shortage of chaplains. So it's not like there are lots of chaplains running around with unused capacity that could be used someplace else. And I happen to think that palliative care is both a potentially primary care responsibility and a place where, as in other areas, there's a need for specialty consultation and specialty insights to help primary care people deal with that task. And so that's the one where that I'm most familiar with. It turns out, by the way, speaking of California and the Midwest, that this whole thing about death panels, about that, is completely made up. It's a completely inside the Beltway myth. We did a survey of Californians, public opinion survey, where we had the actual language that was originally in the ACA. We said, what do you think about the idea of paying doctors to have a conversation with their patients about when and how they want to die? 72% of Republicans said they thought that was a very good idea. So this notion that there's this huge group of people out there who are opposed to any reasonable modern approach to palliative care is first a myth. And second, one often hears, this again back to primary care perspectives and generalists, one often hears, I think, from doctors, when we ask people, why is it that we're giving third-line chemotherapy to people in the last 2 weeks of their lives? Why is it that people are dying in ICUs when they clearly don't want to? The most common response is, well, my patients demand it. No, actually, they don't. My sense is that if we actually told patients the truth about the likelihood that a given intervention would restore them to anything like normal function, and the almost certainty that it will leave them debilitated and nauseated, their choice of chemotherapy would be quite different. So this is an area that as you can tell, I feel strongly about. But this notion that we treat people, I think, in generally not well at the end of their lives, not in accord with their wishes, were they well informed. And it's an area that I think is really a win-win-win area, one that is sometimes politically controversial, but past the talking heads, I think there's broad agreement among people and providers alike that it's one of the areas we've got to do a much better job at. So,
Barb Porter.
Thank you. Thank you, Dr. Smith, for sharing your comments with us. You've mentioned a couple of times your own medical school experience as well as the length of time, 9 years, 13 years, 15 years that it takes to prepare licensed healthcare providers. Mm-hmm. And I believe in doing some research on you, I found that you've given some thought to the pipeline, the undergraduate medical education pipeline.
Right.
You know, the 4 years we're all feeling is not necessarily the best approach.
Right.
What are your thoughts about preparing good physicians in less than 4 years or different models? Well,
we're about to find out, because there are a number of experiments going on, including one at UC Davis, that is going to take people through a 3-year medical school experience and is going to progress them on the basis of what they can demonstrably accomplish as opposed to how many hours they've sat in histology class. So, I mean, when you think about the fact that our basic pedagogy hasn't changed a lot in 30 years, there's not much else that hasn't changed in 30 years. So I think, one, to the extent that we want our system to be affordable, and that is in part linked to how much we pay people and how much we have to pay physicians is in part linked to how much debt they're in, and how much debt they're in is in part linked to how long they're spending in school, economically unproductive. That's a real important thing. More than that, though, I think we face a problem in our profession of each micro profession is so siloed in terms of its requirements that it's difficult to respond to how quickly the biomedical science changes. So I don't know if there are any interventional cardiologists out there or any cardiothoracic surgeons. If you think about the economics of practice now, kind of one development can wipe out the economics of a specialty in a couple of years. If you think about how long we train radiation technologists and for this narrow little slice of what we do, and how quickly biomedical progress is changing, part of the reason our system is so inflexible, so rigid, so difficult to adapt is the kind of training and licensure mindset that we have. So I'm interested in anything that provides us a little more flexibility about how we train people, because basically, to sum it up, the last 50 years has seen this enormous revolution in technology, in biomedical technology, information technology, but our systems for choosing and training and paying and deploying people have a difficult time keeping up with the technology. So anything you can do to shorten the training, to make it more flexible, to make it more possible for people to move between silos, I think is a good thing. And I think, frankly, I'm actually heartened. As you may know, the MCAT has been changed. For the first time, they will actually wonder if doctors have any social skills. I mean, the notion that in 2013, for you to be a doctor, you've got to essentially get an A in organic chemistry, but need not have taken a course in human psychology? Calculus? Physics? Really? So I have to say I actually am encouraged, because I think the medical education establishment gets that we're a little behind the times. It's difficult, but I think we're getting there.
Dr. Bachman.
California Health Foundation monograms, delightful. Changed my life, changed the life of others. Anybody who hasn't looked at your monograms, look at it. If you're trying to get involved in technology, teamwork, the first place to go is your website. You have done wonderful things for people, including myself, and so thank you. I'd also like to emphasize something that you said that's really important, and that is about how we're going to progress forward by getting data. This is Mayo Clinic. Data everywhere, and not a bit to think. What you emphasized was the need to have predictive data to predict the future. We use data here like somebody driving down the car, trying to drive their car forward by looking at the rear view mirror. Yeah. What we need are control charts and run charts, and I just want to emphasize the ability to predict is going to be more important than just having the data. And then the point I'd like you to respond to, though, is there's going to be a tension. And that tension is between the holistic model and fragmentation, which is brought about by the team. As we look at things like strep throat, yeah, there's some people around here that believe that you have a germ, you get it, and you have strep throat. And yet, a holistic model says, no, it's because you're working 70 hours a week at Mayo Clinic, you got yourself run down and tired, and now you got a sore throat. Let's take care of the penicillin, but today we need to talk about your life.
Yeah.
It's not a migraine headache, it's because you're angry at your supervisor and you can't go hit her.
Yeah.
Okay? And so this tension between holistic medicine and then fragmentation, having nurse practitioners and retail clinics, yeah, they take care of the problem, but how about the smoking? How about the other things? And so that'll be something that we'll be sorting out, but I think, again, by using prediction and using a different set of analysis. So comment a little bit more about holistic and fragmentation.
Yeah, I think that's excellent. So much of the impetus for primary care in the United States came as a reaction to the hyper-specialization of American medicine and to kind of a desire to return to what was in some ways a fantasized past, but the reality of someone to integrate and coordinate these perspectives, a guide to the system, which we still need. And yet, most industries, most service industries, elaborate different platforms for people from which they can choose, based in part on their preferences and based in part on the level of service that they need. So if you have a car and you've got an old car and the muffler is bad, you take it to Midas Muffler. You don't necessarily take it to the GM dealership. So that analogy may grate on you, but it's not a bad analogy if you think about the strep throat and family doctor analogy. There are some patients who, for some conditions, need a mensch. Do you know what I mean? It's a technical term. They need someone to talk about their whole life and this and that. There's some people, if you're a woman who's had a UTI before and you have a UTI again, you may not want to talk about your marriage and your whole life. It's like, boom, can we get this done here? I'm busy. I got stuff to do. So I think part of the tension is both philosophically and operationally between what can sometimes devolve into a one-size-fits-all. So my best example of this, anybody here a pediatrician? So when retail clinics first started, I made a trip to Minnesota several years ago at the very beginning of retail clinics to try to understand what this phenomenon we were hearing was all about. And came back kind of a believer in it, as I still am, with the right circumstances. American Academy of Pediatrics put out a statement opposing retail clinics because it said, we are for the patient-centered medical home. This is not a medical home, therefore we're against it and we urge our patients not to use them. To which the question really must be raised, so what would you have someone do at 7 o'clock on a Sunday night? Wait until you're available? Sit all night with a screaming kid? Go to the ER? None of them sounds like a particularly good option, and yet there is the challenge of not only integrating the clinical information, what was the test, what antibiotic, with this electronic medical record, which the pediatrician probably didn't have, but the larger question of, well, is this the second or third strep throat? Are you a nervous mom? So I completely agree with you. And I guess the only answer I have is, my ideal is that there's an organizing intelligence that is able both to have this information and to use some predictive models, because there ought to be somebody, somewhere, not a body, an organization that says, you know, this is the third retail clinic visit in the last year and a half. High priority, let's get this person in, let's talk to her or him. The notion that an individual is going to do it, I just don't buy. But I agree with you. It is a tension. And there's a certain philosophical tension between I'd like to control everything, I'd like to be in charge of everything, I'd like to know everything the patient does, versus the patient gets to pick and choose which platform they use. I showed the group in the Innovation Center earlier. I get my care from Kaiser Permanente. So to the extent that one votes with one's feet, that's what my vote is. I got a mailer the other day that said, we're trying to save you time. At the bottom it says, we're here to take care of you however you'd like. Online, email, phone, or come in and see us. And in part what they're responding to, I think, is the reality that different patients will have different preferences, different levels of need. In that case, they're big enough, they have their arms around enough of the system to be able to integrate that information. But ideally, that's what we should be doing. There are some things for which I should be able to call somebody and get advice, or email my doc, or go to the retail clinic, or check my symptoms online. There are other times I ought to go sit and talk to somebody one-on-one, and hopefully we've got a system that's mature enough and optimized enough to offer the right thing to the patient that needs that thing or wants that thing right then.
Our time is about up. I would like to follow up that question, Dr. Boss, with one short one, if I might.
Okay.
So we've talked about lots of data, but are we really measuring the right thing? So is health measured in terms of 5 process measures for diabetes, or is health better measured in how you're able to do your job every day? How well you're able to function as an individual? How well you're able to be the person you want to be?
I think it's some of both, and frankly, some of our conversation about diabetes is still rooted in kind of the curative perspective, that the most important thing is your hemoglobin A1C and your blood pressure and whatever. I think increasingly, particularly younger people are interested in their function. Certainly employers are interested in whether they can come to work every day. So I think there's a role for both. The fact of the matter is our system is not right now paid to keep you healthy or happy. It is paid when something goes wrong, and the more intensive our approach to that, the higher the reimbursement. I think we'd all like to see a system where we can get the reimbursement system to catch up with the biomedical science that says we now know what to do to keep you healthier and happier, but people respond to incentives. To the extent that our organization does well financially by succeeding at that, that's when I think you'll see an explosion of our creativity in doing that, in the way that we're quite creative now about figuring out the latest organ to interrogate or orifice to cannulate.
Very good. So Dr. Smith, thank you for really a great unexpected conversation. And I actually want to thank all of you in the audience for coming and participating. I want to remind you that the next installment of this series will be on March 6th, and so stay tuned. That will be Dr. Tasha Yamada, who will be coming back to Mayo, somebody we know well, but stay tuned for that next conversation. In the meantime, I hope you'll take to heart some of these very provocative observations and think about them as we think about how we're going to make a better Mayo Clinic for the people that we serve. Thanks again for coming, and have a great holiday, everyone, with your families and those you love.
I hope
Thank you,
that was
sir. It
helpful.
was great.